Good afternoon, good morning, wherever you've tuned in from. I am delighted to have an excellent panel with me for this webinar, which is financial sustainability for private hospitals involved in this COVID-19 situation. My name is Dr. Amit Thakker. I'm the president of the Africa Healthcare Federation. Joining me on the panel this afternoon is Dr. Mark Hellowell, who is based in United Kingdom, just outside Manchester right now. I've also got with me Dr. Albert Tuyishime, who is based in Kigali, in Rwanda. And also joining us is Dr. Tryphine Zulu, who's based out of Johannesburg, South Africa. I am very, very happy that many of you could log in at this time and join us for this important conversation around private healthcare, private hospitals, private clinics. And I've seen attendees who are from all parts of Africa, and thank you, Ethiopia, thank you, Nigeria, thank you, Algeria, and East Africans and Southern Africans who are on this panel. Next slide. I also want to thank the team from Africa Healthcare Federation who's joined us, who are supporting the panel in the back room here. Thank you, Barbara, and all the team members who have put this together. Let me begin by saying that at the centerpiece of this slide, you will see the role that Africa Healthcare Federation plays. And through the 5 regions, we are trying to organize peer-to-peer learning systems through regular webinars on West, South, Central, North, and East. We also have a Francophone series to ensure that the Francophone team also has a peer-to-peer learning system. So you can stay tuned and connected for our webinars as we discuss important topics. The main idea is to connect with the Ministries of Health, Africa CDC, Africa Union, and World Health Organization. On the 16th, we will have a conversation with the World Health Organization, AFRO, on the role of the private sector in COVID-19. Next slide. The Africa Healthcare Federation is a formation of 14 years of work of many champions who've logged in to the call today. They have sacrificed their time in coordinating and organizing the private sector. So about 30 countries have got a strong or a semi-strong federation, as you can see on this slide, divided into the 5 regions. The bold abbreviations indicate organized and registered federations that engage with the ministry on an ongoing basis, and many other countries are in formation. Next slide. Before we just jump into the private sector with the esteemed panelists, I just want to remind everyone that when we talk about the private health sector, it refers to the non-state health sectors. And you can see how diverse we are. And many studies indicate that over 50% of the services are provided on this continent by the private sector, whether you call them the formal providers or the informal providers. Look at just the amount of breadth that we have in providing services across. In some countries, the private sector is much stronger than the others, but collectively, I think half the continent will win the fight against COVID if we do support the private sector. We also want to emphasize that the faith-based organizations are a key partner in what we do and how we work in different countries. Next. So what we did when the COVID outbreak happened, and we were watching what China went through, what Europe and US went through, is to quickly formulate a structure that you see in front of you under the private sector engagement framework that WHO is very well aware of. And we started adopting it to how the African healthcare federations in country will work. We want to get organized. I think that's one of the big things that the team behind is doing. The second point was to marshal space and have innovative infrastructure, activate staff, ensure supplies. And talking about supplies, You're well aware that over 90% of the products being supplied in the healthcare industry come from the private sector. And you have all seen how the manufacturers, because of the interrupted global supply chain, have repositioned themselves on manufacturing PPEs in country using available raw material and resources. We are also setting stage to create systems in order for us to wade through this COVID-19 outbreak and come out as a stronger health system in Africa that can resist and fight future pandemics and epidemics, so our economies don't get damaged. So creating a strong system is an important pillar of our work. Getting resources, it's critical. And you all know with limited resources, the first dollar tends to support the public health system, and probably rightly so. But in this unusual outbreak, we need to also get resources to support private sector. And one of the discussions today is how do we support private hospitals when income has really shrunk and the costs are increasing and the demand for the COVID patients start coming through the door. ICT and mobile health is another cross-cutting engagement that we're trying to promote through telemedicine and telehealth. Next. So I think this is really how I wanted to set the stage of what we are doing and how we envisage many of these discussions leading to a robust system. I would like to welcome Dr. Mark Hellowell warmly to this panel and ask Mark to begin his presentation. Mark, over to you.
Thank you, Dr. Thakker. It's a real privilege and a delight to speak to this issue and to speak to you all today. I just want to just very briefly say something about why I'm on this webinar as an academic based in the United Kingdom. So Dr. Thakker mentioned that the WHO, Barbara O'Hanlon and colleagues, have put together an action plan for engagement of the private sector for the COVID-19 response. And as a broader package of work, Barbara and I are working with the WHO to look at some of the challenges that governments are facing in engaging the private sector and trying to provide some advice to countries so that they can better coordinate the public and private sectors in terms of the national response to the pandemic. And as part of that work, Barbara and I have been speaking to as many stakeholders as we possibly can, particularly in developing countries that are experiencing an upsurge in demand for healthcare right now as a result of the pandemic. And what we're hearing is that there are a number of fairly common challenges across different countries. One of the challenges that is repeatedly mentioned to us by private sector respondents, but also by others, is the financial challenges that many private sector businesses in the healthcare space are experiencing right now. And so we're very interested in examining that topic going forward and trying to get a sense of the key dimensions of the challenge and what solutions might be introduced in order to address that challenge through national action and also through technical assistance and other forms of support that the WHO can provide. So that's really the basis for my presentation here today. I'm going to talk about some of the challenges that people mention in relation to the financial challenge that businesses face at the moment, and also just talk through very briefly some of the responses that countries closer to my home have adopted. There has been a strong emphasis here on purchasing strategies and new forms of regulation from the state that have been, I think, to a certain extent mischaracterized in a lot of media discussion and public discussion as nationalization. But as I hope to be able to touch on in this presentation, the reality is a little bit more nuanced than that. And really, they're more sort of contracting arrangements than they are any form of nationalization. Next slide, please. I just want to provide a bit of a framework for this conversation. So I think when the WHO team started to become interested and concerned about the lack of public-private coordination in responding to the outbreak in many countries, we initially, I think it's fair to say, saw the problem primarily as a health system problem, and not so much a problem that was a sort of more whole of society problem. And I think one of the reasons that we went at it from that point of view is because what's happening in places like the United States, especially the east coast of the United States, and in northwestern Europe, is that we're deeply in the mire of the mitigation phase of the epidemic. In other words, we are already seeing the big surge in demand for healthcare, both in terms of COVID-19 related healthcare and other forms of healthcare, that you get when you're climbing the peak of the epidemic, as we have been over the last 4 weeks or so. So looking at, for example, at Lombardy in northern Italy and the extreme stress that the health system in that context was facing, we began to be very concerned about how that kind of situation would play out in other countries, and especially in developing countries with relatively weaker health systems. And so we were primarily concerned to ensure that the public and private sectors were well coordinated so that they could collaborate in an effective way in responding to that surge in demand. But what we found, I think, when we started to look at the evidence and we started to speak to people on the ground, is that many countries have not yet experienced that surge and are not yet in the mitigation phase of the epidemic. They're still in a containment phase in many cases, and they're still hoping that they will succeed in not just flattening the curve, which is what we're trying to do over here in Europe, but avoid a large outbreak in which there is substantial community transmission of COVID-19. So many countries are still in this containment stage. We hope that they will be successful. There are ways in which governments and others can engage the private sector in supporting those containment measures. But one of the things that we would like to say is that while countries are focusing on containment, that is an excellent point in time to start thinking about planning for the mitigation phase, planning to ensure that health systems are optimally resilient to what could be a very large-scale surge in the near future. And in the near future means within the next few weeks and months. So that's worth pointing out, that in LMICs we see perhaps in many countries at least, we see less engagement between the public and private sectors. But it has to be said that where we've seen deep engagement in many countries in Europe, that has only come about as a kind of reactive measure to the big surge in demand for healthcare that's come about as the epidemic has developed, and the control and mitigation stage is attempted in earnest. Okay, next slide, please. Okay, so just in terms of the kinds of responses that we're getting from key informants we've approached in developing countries, I mean, obviously we're speaking about common experiences here, and every country is very different. But we have been interested to hear from people about the causes of the current pressures they face in relation to financial sustainability. Of course, many of these pressures are common across multiple sectors of the economy. This is not just healthcare specific, but healthcare is particularly exposed because of some of the regulatory interventions that governments are putting in place. So as a matter of fairly common experience across jurisdictions, many private healthcare businesses in developing countries are facing a substantial reduction in the demand for their services, and that is having a clear impact on their revenue streams. Some of this, as I say, is to do with the general economic dislocation which has accompanied the pandemic. But government regulations often require some healthcare facilities to change the pattern of supply in various ways. So in India, for example, and in many other countries, regulations have required or have requested healthcare facilities to defer non-urgent or non-essential health services, often, though not always, for an indeterminate period. And so that has materially changed the way that healthcare businesses are running and operating at the moment. Many countries have lockdown restrictions of various levels of severity. So it seems that many patients that don't have COVID-19 related symptoms are still not, for various reasons, either because they cannot or for some reason they're reluctant to attend healthcare settings at this point in time. This seems to be an international problem. It's a problem that we're seeing here in Europe, whereby, even people with very, very urgent healthcare requirements are not presenting in healthcare facilities. In a context like the UK, this is a population health problem, but in countries with a larger private sector than we have here, it's also a commercial problem. So there's a general problem of economic disruption due to the pandemic, reducing the willingness and ability of people to pay directly for healthcare services. I guess we're still at an early stage in those terms, but in some countries at least, people are starting to lose their jobs, especially their formal sector jobs. Many people are moving into the informal sector or into unemployment, and there's a general reluctance to run down savings or to borrow, and indeed a lack of credit for people to pay for healthcare at this point. So, for all these reasons, there's a restriction in demand, a reduction in demand, and also in the ability to pay. In some countries, and this is perhaps a longer term issue, the number of people with insurance or the proportion of people with insurance, whether that's national insurance or private insurance, is diminishing. And that's likely to continue as the full economic effects of this pandemic roll out. And again, in the longer term, that's likely to further reduce the demand for care in terms of the ability to pay for it. Next slide, please. So there are a range of things that policymakers can do, and I'd be very, very interested to hear from my co-panelists, but also the participants, on what those solutions may look like. Clearly, governments and their partners may wish to provide some kind of financial support for healthcare businesses at this time. That's likely to be important in terms of the economy in general and the health sector in particular. If we do in the coming weeks and months see in these countries a big surge in the demand for healthcare, then we want to make sure that what capacity exists in the private sector is going to be there. And we certainly don't want healthcare providers at this point facing insolvency or laying off staff in ways which will undermine the response in the longer term, especially as we move from that containment phase to the mitigation phase. I think at the moment, one of the things that is holding government back is that there's a lack of clear criteria for actually deciding which businesses to support and how best to support them. So governments, in health sector terms, clearly governments need to think about what are the systemically important healthcare businesses, and how can we make sure that those businesses are at the front of the queue when it comes to support from us or from development partners or whoever. We need to make sure that private sector businesses that play a systemically important role are supported, and we need a clear criteria for making those sorts of decisions. We also need to think about how that support is going to be provided. So is it going to be provided in relation to things like patient volume guarantees, forms of tax relief, direct subsidies, and how can we ensure that that support is structured so as to enhance both the national COVID-19 response as it rolls out over the coming weeks and months, but also strengthens health systems and the coordination between the public and private sectors in the longer term as well. Next slide, please. So I'm speaking from the United Kingdom, so I just wanted to talk briefly. I don't know how long I've been talking. I'm probably running over. But just
Mark, you've got 3 minutes to go. You can wrap up in 3 minutes, okay?
I'll wrap up in 3 minutes. So I just want to say that different countries here in Europe, where I'm based, have done slightly different things in relation to engagement of the private sector. So Germany, as a country, is probably one of the best performers here in Western Europe. They've successfully, it appears, contained the outbreak and have had very modest numbers of hospitalizations and deaths compared to, sadly, here in the UK. One of the reasons for that is that they were extremely successful at engaging private sector diagnostic capacity as soon as this outbreak was anticipated. And as it happens, private sector diagnostic capacity in Germany is very substantial, but that was engaged relatively quickly through routine reimbursement schemes for diagnostic services, through the national insurance systems and the sickness funds. They were able to quickly ramp up purchasing of tests, and that has been a major factor behind Germany's relative success at containing the outbreak. So that's a good experience, and one that I think other countries could potentially learn from, although they're probably operating a very different kind of health system and different governance regime for the private sector. But next slide, please. Unfortunately, here in England, we were much less successful at containing the epidemic. And so we have got to that stage of having to try and mitigate the epidemic and try to get the health system prepared for the big surge in demand that has occurred. One of the ways that they've done this is they've contracted with really the entire private healthcare sector, and in particular the private hospital sector here in the UK, which is relatively modest in comparison with many other countries. But nonetheless, they put in place a range of agreements covering essentially the full range of staff and systems and supplies that were needed to effectively respond to the COVID-19 outbreak. And they put in place contracts that were based on, modest profits, what they call zero profits, but I'm not sure that they really mean zero profits. But they have relatively cost effectively engaged the private sector, provided the sector with significant demand for its services, and put in place a reasonably robust system of reimbursement, and done that relatively quickly. That's important now in terms of the COVID-19 response. It will also be important as we move to the next stage of the epidemic, when we're looking not only to continue to flatten the curve of the epidemic, but also provide services to those people who, for one reason or another, haven't been attending hospital and now are in need of care quite urgently. And the private sector will need to play a role, and will play a role under these contracts in servicing those healthcare needs. Okay, I think that I am done, so I will stop there. Thank you very much.
Thank you, Dr. Mark. That overview is really amazing, and it brings us to this segue. You talked about nationalization. We'll talk about that a bit later. But I think one thing you talked about was contracting in for private facilities, and this provides us very nicely to move to Dr. Albert. Dr. Albert Tuyishime is from the Rwanda Biomedical Center. And when we talk about Rwanda, some countries in Africa shine, like Rwanda and Ghana, when we talk about healthcare financing in UHC and coverage. And Albert, you might tell us how RSSB and contracting and funding might be helping the private sector facility in Rwanda. And many of the participants who are here are dealing with government payments like NHIF and NHIA in Ghana and other private insurance. So over to you, Albert. Thank you for spending time with us and sharing your thoughts. Please welcome Dr. Albert Tuyishime. Over to you.
Thank you very much, Dr. Amit. It's really a pleasure and a privilege to be on this webinar and be able to share our experience vis-a-vis this pandemic, COVID-19. The setup in our response might be different from the classic one we used to have, and I will try to explain as I go through my slides. Next slide, please. As we all know, the National Health Insurance is there just to make sure that people have access to health services they need, when and where they need, without financial hardship. It has to cover a full range of essential health services, from the health promotion, prevention, treatment, and care, but also minimizing the out-of-pocket payment. In our country, we have more than 90% of citizens who are covered with our national health insurance scheme. Next slide, please. In Rwanda, we have three main categories of health insurance schemes. And the biggest is the community-based health insurance, which is covering more than 8% of our population. And in order to be functional, but also to be sustainable and be able to respond to the expectations from its member, we have premiums paid by members of the insurance scheme. And these premiums, they are set based on the socioeconomic categories, which are done by our Ministry of Local Government, and it's done for everyone who is living in Rwanda. And from those categories, that's where we set the amount of premium everyone will have to pay in order to benefit from the community-based health insurance. But these premiums, they are not enough to run the scheme. That's why we have different contributions from different institutions, whereby we have the Ministry of Health contributing some of the registration fees for pharmaceutical and medical products, but also some revenues collected from researchers earmarked to support the community-based health insurance. But also we have the Rwanda National Police, which is contributing to that scheme, specifically from the some of the services provided by the National Police, namely the vehicle control services, but also from the road traffic fines. We have also the ministry, the government through the Ministry of Finance, which is contributing 6 billion Rwandan francs, which is around 5.2 million USD per year to support that community-based health insurance. But also, in addition to that yearly contribution, the government of Rwanda is paying 2,000 Rwandan francs per needy person in Udehe 1. Udehe 1, they are those families in the socioeconomic category 1 in the poverty. So you have this Ministry of Finance paying 2,000 per person from that socioeconomic category. We also, next please, we also have contribution from telecommunication companies, which are paying 2 to 3% of the annual turnover to support that community-based health insurance. We have the Ministry of Trade contributing its 10% of all fees charged on services offered to gaming companies. But also we have the Rwanda Standards Boards, which is in charge of making sure services products are meeting the quality standards. So this institution will be contributing 100% of the amount collected as penalties for trade and substandard products. And this will be earmarked to the community-based health insurance scheme. But also we have recently introduced another contribution from the public servants who are going to be contributing 0.5% over their gross salary. And this will be earmarked to support the community-based health insurance. So this is the main health insurance scheme we have in Rwanda. But on top of that, we have a health scheme specific for public servants. And this will be functional due to the contribution from employees and employers. And it does cover all public servants. In the third category, we have private health insurance companies, and these do require their members to contribute some premiums in order to benefit from their services. Next, please. So the national health insurance being the community-based health insurance, but also that one for public servants, it's being coordinated and directed by the Rwanda Social Security Board. So it will be the one in charge of collecting the contributions, premiums, but also paying the services provided. On the side of service provider, we have different health facilities being public or private. And we do have different levels in our health system structure, where we start from the community with the community health workers, then we have health posts, then we have health centers, district hospitals, provincial hospitals, and referral hospitals. And at each level, we do have a specific benefits package defined for each level. And here I have to mention that members of the community-based health insurance scheme, they do receive primary health care from health center or from any health post anywhere in the country. So if I'm living in one village and I have paid my premium, I'm able to get health services covered by this scheme whenever I'm or wherever I am on the Rwandan territory. Next slide, please. So who are the beneficiaries for our national health insurance? As I said, for the community-based health insurance, the beneficiaries are household members. And for the public servant health insurance scheme, beneficiaries are public servants, meaning those working for the public institutions, and we'll have people who are able contributing or paying for a private health insurance. And I have here to mention that for those public servants, they will be covered by that insurance scheme, but whenever they go for healthcare services, they have to pay 15% of the cost for the medical treatment and the drugs, and the scheme will be paying 85%. But this is applicable to that scheme covering public servants. Next slide, please. Now, in this pandemic of COVID-19, those different schemes or the national health insurance scheme, we have not changed our package. Why? Because the government of Rwanda has decided to cover all COVID-19 related services. So that's why it has set up specific and specialized centers or sites in charge of following up COVID-19 patients and providing related services. Other health facilities and health service provision have not changed. So what we have done, we have requested every health facility, being public or private, to identify and allocate a space where COVID-19 suspected patients can receive health services, waiting to be referred to those specialized or set sites. And in order to make sure the usual health services are not interrupted, the government of Rwanda has made some amendments on the validity, but also on the payment modality. One, on the validity, we used to have 30 days before the health insurance is valid, but right now that one has been removed. As soon as you pay your health insurance premium, you are eligible and you can go and get health services immediately. But also, the government of Rwanda has encouraged online payments of the premiums or contributions. The two targeting to make sure the rest of the health services are not interrupted during this COVID-19 pandemic. Next, please. So far in Rwanda, we have 261 cases of confirmed COVID-19 patients, and among them, 128 have recovered, and we still have 133 active cases in the treatment centers, and we have not registered any death related to COVID-19. As I said, we have set up COVID-19 treatment centers, and all service cost is covered by the government of Rwanda. The tests are done and confirmed at the Rwanda National Reference Laboratory, but we have different teams across the country in charge of contact tracing and sample collection. And as soon as the sample is collected, it is sent to the Rwanda National Reference Laboratory for testing. Next slide, please. So briefly, this is how we are dealing and providing health services in Rwanda. And I'm happy to provide more details or additional information as we discuss on this webinar. Thank you very much.
Thank you, Dr. Albert. Our appreciation to the work that the Ministry of Health Rwanda is doing. Our greetings to Hakiba Solange of RSSB, to your new PS who is in the Ministry of Health.
Yeah.
And you have shed a lot of light, especially on the support that the government is giving. And Rwanda is well known for that. You will see this is not the same in many parts of Africa, where they are being asked to pay for treatment, especially in the private sector. And we will come to the discussions on that. And all costs you mentioned are covered by government of Rwanda. That is really, really something, and I hope that can be sustained. We're more in the discussion. Please let me welcome Dr. Tryphine Zulu, who is joining us from Johannesburg for her presentation before we go into the Q&A and field the questions you've asked and have a dialogue. Dr. Tryphine Zulu, over to you.
Thank you, Dr. Amit. I don't know, can you hear me? Is it clear?
Loud and clear.
Yeah, we can hear.
Thank you. So I'm going to be presenting on balancing the sustainability of private hospitals or the private sector in general with the financial sustainability of the healthcare sector as a whole. So I'm part of the advisory group that you mentioned, Dr. Amit, with Barbara, of the World Health Organization, where we're looking at the private sector engagement or private sector governance for UHC. But I primarily work in the private sector in South Africa in the funding space for the government employees medical scheme. So I'll be sharing my personal experiences from the work that I do, and I'll also be sharing with you just in general what the private sector space looks like from a financial sustainability point of view. So by way of introduction, the healthcare financing in South Africa is set up into two main sectors. So there's a state-run public sector, which is financed from general taxes, and for the most part is progressive taxation. So you have your taxes pay as you earn, and then there's also some direct taxes like VAT and SIM taxes. It is also the private sector, which is financed from health insurance predominantly, and there is some level of out-of-pocket payments, but for the most part, admissions to hospitals are financed through health insurance schemes. We currently have about 79 schemes that cover different sectors. In my case, I work for the government employees. There's also other schemes that will cover private sector workers, and also individual people, private citizens can sign up for cover into a health insurance fund as long as they can afford it. And from a governance point of view, we have a fairly strong governance structure for the medical schemes or the health insurance schemes, and we are regulated by the Council for Medical Schemes under the Medical Schemes Act. So the work that we do, the benefits that we come up with are all regulated under this Act, and that sort of provides some sort of cover for or protection for the citizens that sign up. And in terms of purchasing, because we have these different 79 schemes, each scheme would contract with a different, in terms of contracting with the healthcare providers individually, unless if there's some other mechanism put in place in terms of signing up with an intermediary, which in our part of the world we call managed care entities or administrators that might do that on behalf of the schemes. But in the main, the schemes would do this independently between the providers themselves. Next slide, please. So in terms of the reimbursement mechanisms, the private sector is predominantly financed through fee-for-service, whether it's a hospital claim or a claim from a specialist or consultants, as some might call them. There is a predominance of fee-for-service. There is some level of what we call fixed fees for hospitals, where instead of getting an itemized bill for theater, for the nursing, for the consumables, you get a fixed fee that would be based on the length of stay, and that's for specific procedures. For instance, for obstetrics, that is your maternity care in hospital for the delivery of the baby. So you do have fixed fees, but that's not in the main. So what we normally see in the sector is fee for service. But also because of the nature of the contracts, there's a lot of administrative costs that come with it. Hence, that also tends to increase the cost of running the health insurance schemes as well. Next slide, please. So I'll speak on the impact of COVID so far from a utilization point of view. So in the past 4 weeks, I think during the lockdown, we saw a 50% reduction in admissions overall, and it was most prominent for surgical admissions, and followed by medical and also for obstetric care. But what would be most surprising is we wouldn't expect to see such a large decline for the medical conditions, because these for the most part are not planned admissions. So one might, in terms of sustainability, it might also point to the issue of supply-induced demand, but also it might be due to unmet need. But so if you look at it from a health financing point of view, one might ask, is it a saving for the insurance industry and a loss for the private hospitals? At this point, I think it's too early to tell, and I don't really think it's a saving as such, because the long-term impacts are not known at this point, or the outcomes. And we do expect a surge of admissions after the easing of total lockdown, particularly for elective surgical admissions. And as I mentioned, it was we did not expect to see as many as such a reduction in medical admissions, which we think might be related to to an element of supply-induced demand, or at least inappropriate utilization of admission of hospital care. On the next slide, the question was, can you speak to us about the challenges of managing a COVID patient? So in our case so far, we've seen a fairly low percent of those patients that test. Looking at things like the pathology costs are higher. The cost of isolation in private wards as well is quite high compared to a normal admission that would have gone to a general ward under normal circumstances. So also the idea of isolating a person under investigation whilst waiting for results, that might take a day or two. That day or the 2 days also costs quite a lot. And that drives the admission cost for a COVID patient. And also there's the cost of still here to look after as a health insurance scheme or as a health insurance fund. So what we're seeing, because of the lockdown, or because of staying away from hospitals because of COVID, there's a potential delay in accessing care. And the most, I would say maybe in terms of the concern, it would be more in the mental health space, where we in South Africa have a predominantly hospice-centric approach to management of mental health. So because we don't have a strong community-based approach to mental health, the impact on this group of patients is likely to be higher. And then in terms of access to chronic medication, the recently released survey from the Human Sciences Research Council mentioned that about 13% of respondents could not access their chronic medicines. Whilst maybe in the space where I'm in, the insurance fund that I'm working for, we've seen an increase in chronic claims. It does happen, and it has happened that some people are not able to access their chronic medication, and that obviously leads to complications due to non-adherence. And you would know that we've got a fairly high proportion of HIV positive members in particular, and in those people, it's important that they stick to their treatment regimen. So that would be our biggest concern. But like I said, for the fund that I work for, that has not been such a big concern, primarily because we opted to go for the courier pharmacies, where you deliver the medicines to the patient in their home, to cater for the issue of lockdown. And then the second point is the closure of affected hospitals. We've had quite a few private hospitals that have closed down as a result of COVID, having staff members infected with COVID, or patients being infected in hospital with COVID. This actually disrupts access to care, particularly for emergencies or urgent care. And what we've had to do in our space is to make sure that you communicate with members, you make them aware that there are other alternatives. But in the main, the closure of affected hospitals does reduce access. And then the other part that we just grappling with right now is, how do we get patients back in for elective procedures? Because even if you test upfront, the extent of spread within the healthcare facilities is unknown. And we have seen this come up. Hence, some of these hospitals are closing down. So it is one of those things that we're trying to grapple with, to say what will be the impact of reopening elective procedures in terms of the cost and sustainability of the industry. And then on the next slide, I've mentioned the cost of PPE. So here I'm talking to a few friends that are in the private sector in hospitals. One of the issues has been the issue of quality. How do you ensure that you get standardized quality across all the hospitals that are getting PPE? And also because there's a siloed approach to procurement, there's also the risk of higher prices because there isn't a combined or concerted effort to negotiate and buy in bulk. Maybe because the times don't even allow for it. I mean, we're all in an emergency here. But that on its own is also driving the cost of care for a COVID patient. And then ultimately those costs are passed down to the patient or the funder in our case, because it's not being provided for free. Hospitals still need to recover their costs. And I think some of the solutions that we could consider here is procurement of PPEs in bulk across the private sector and definitely across the entire health sector, including the public sector. And also to incentivize local production where possible. We've had examples where at universities there's 3D printing of the face mask, and then we could also incentivize local manufacturing of some of the PPEs. But obviously, compared to importing from China, the guys that have been doing this for a long time, and they can do it in bulk and with quicker turnaround. I think it's also a start to start talking about incentivizing the local economy, particularly given that with COVID, there are job losses that we expect or that have already happened. So I think for me, that's one of the things we could do in the private sector to make sure that, one, we bring down the cost of PPE. Secondly, also we can be assured of quality, at least because it's local production. And thirdly is to boost the economy. On the next slide, the other challenge is also related to testing for COVID. If you look at the graph to your left, these are the prices that were available on the market since in March, between March and now in April. So they've come down in some instances from 1,400 to around 650, but it doesn't necessarily mean that the pathology lab that was charging 1,400 is now down to 650. So these are the prices that are prevailing in the market right now, and it varies from one lab, from one pathology lab to another. But when you look at this kind of pricing in the private sector and the numbers that are actually coming forward for testing, the current prices are not sustainable in the long term. And because we suspect that as the lockdown regulations are being eased going forward, there will be an increase in demand for testing. But at the current prices, we simply cannot afford this amount of capital outlay to fund these tests. And in my view, I think there is room to drive this cost lower. Probably we'd have to do that through collaboration within the sector in order to drive down these costs which are associated with testing. And moving on to the next slide, I just wanted to share with you some of the learnings, particularly in the ambulatory care for outpatients who are not admitted, or the non-COVID patients. We've seen a reduction in admissions. But whilst it's too early to tell if this reduction is a true reduction, I think when you look at the medical cases, it does point to the fact that maybe some of the mild medical cases can be managed at home. If they've been able to cope at home at this time, maybe that's where we should be focusing our strategies at, trying to beef up and to develop community-based care. To reduce the inappropriate admissions as a result of the hospital-centric nature of healthcare delivery, which in the long term is not sustainable for anybody. And then we've got to manage the crowding out of other services through community-based care. For instance, there are concerns about reduction in preventative care uptake, and also reduction in other needed outpatient services because of COVID. And we also need to build a strong referral system with GPs as coordinators of care. So in our setting, there isn't any strong referral mechanism that stop our members from going directly to a specialist, unless if you have specific rules that you put in place to say you will go to a GP first and then be referred. But in the main, going to a specialist is really not seen as there's nothing stopping members rather from going to see a specialist. And that drives the cost, because in any event, the probability of being admitted after having seen a specialist is really quite high, and that drives most of the cost in the private sector. So we need to explore different arrangements, which include global fees for multidisciplinary teams in the ambulatory space, and that's especially for mental health. And then my thinking around this issue, particularly as it relates to COVID, is as COVID progresses, the spread and the severity, there will come a time when hospitals are inundated with patients, and they will need community-based clinicians that they can offload those recovering patients to. So in my view, we need to start to think about community-based care in that way, particularly as we deal with COVID, because when these patients are discharged home, they might still need somebody who looks after them in the home instead of keeping them for longer in the hospital. And we have also started looking at telemedicine for specific disciplines as an alternative to make sure that there is continued care, even as patients are at home. They should be able to get care via virtual consultations. And the scheme that I work for, the insurance fund that I work for, is already doing that, and we're implementing that. On the next slide, so in terms of the regulatory response to COVID, the regulator that I mentioned on my first slide, the Council for Medical Schemes, has expressed an intention to declare COVID-19 a PMB. So they've released a circular that says COVID-19 will be a PMB. So at the moment, we're just waiting for the regulations to be promulgated into law. So what that means, when a condition is prescribed minimum benefits, means it's a legislative requirement to provide those benefits for the diagnosis and treatment of the condition. And the idea is to protect the insured population from out-of-pocket payments. And we've also seen regulations in the non-health sector that allows collective engagement between funders and providers for the purposes of reducing costs related to COVID-19. And there is a proviso there. It has to be done under the auspices of the Ministry of Health. And in my view, this is likely to reduce, if funders come together to engage hospitals or maybe pathology labs and wherever else, it's likely to reduce the unit cost of these services, which in the long term will reduce the cost of healthcare. And I think even beyond COVID-19, maybe that's the kind of thinking we should be considering in terms of collective engagements, because the idea of engaging individuals, like I said, there's 79 different funders at the moment, as per the 2018-2019 report from CMS. So the transactional cost of engaging each different provider, and it becomes really expensive. Hence, it also drives the cost in the private sector. So I'm thinking maybe going forward, this is something we could consider, not just for COVID, but for everything else. And then the other issue, though, that we grapple with in the industry is, even though we have these prescribed minimum benefits to guide sort of what should be provided as a basic minimum, there's still challenges in terms of interpretation, in terms of how we pay for these services, which is something that I think the council has considered. There's been some engagement and groups put together to try and review these prescribed minimum benefits with a view of optimizing and at least trying to change and address some of the challenges that have been raised. Moving on to the next slide. So we look at what threatens the financial sustainability of healthcare financing under COVID. So in the private sector, COVID has come at a time when there's already issues. So it can only exacerbate the existing issues. So if you look at the age distribution of members, you will see that there is a very strong element of adverse selection. It's older and high risk members that sign up for health insurance. And that is to be expected because of the cost. I mean, those are people that are paying, predominantly is coming from their own pocket. And unfortunately, the viability of health insurance funds depends on the size and composition of the risk pool. So if you've got older and high-risk members, obviously utilization will end up outstripping the contributions, and that might actually lead to the whole system falling apart. So adverse selection is a big problem. And the second thing that links to COVID in particular is that membership is linked to employment. So as you've seen in the news, there are job losses all around us. So as more people experience job losses, we will see a shrinking of the risk pool, and eventually, I mean, it also exacerbates this issue of adverse selection. And if you look on the middle graph there, it's actually a mirror image of the first one. The members that sign up to be in health insurance schemes, their utilization is also very high. So I've put the percentage of beneficiaries using visiting medical specialists as a proxy for utilization, and you will see that the pattern is just the same. It follows sort of the membership patterns. So the utilization behavior, as I said, in the absence of strong referral pathways, in the absence of care coordination, and in a fee-for-service environment, is also one of those factors that threaten the sustainability of the private healthcare sector in South Africa. And also, if you look on your far right, on the expenditure distribution, most of the financing that comes from the private sector goes to private hospitals. And you'll see that that is at the expense of primary healthcare, your GPs or your day clinics or subacute facilities. Those don't get as much funding or as much utilization as a private hospital. So this is primarily driven by the perverse incentives that are offered by the fee-for-service environment. And you see it as well in the outcomes. So it's almost like a positive feedback loop. There's longer length of stay, there's high admission rates. All of these also drive the fee-for-service behavior. And they're driven by the fee-for-service behavior. There's high admission rates, including those of less severe cases. We've seen it in the past. During the lockdown, we saw a reduction in admissions of even medical conditions, which also tends to support that maybe some of the admissions that we're seeing are not as severe. And then and they should be managed in the out-of-hospital space. We've got also a very high readmission rate, and as just one of the outcomes, we've got a high cesarean section rate as well. So the fee-for-service environment that we have also is one of the reasons that actually threatens the financial sustainability of the healthcare system. On the next slide, so what really needs to be done? So these are just my thoughts on what we could do going forward. So to start with, there is a need for behavioral change, be it the way that the way we procure services and the pricing of COVID-19 related care as an example, and also other services. The issue of care coordination has to be spoken about. We have to deal with these kind of things if we want to reduce and reduce the cost of healthcare delivery. We also need to explore solutions that move utilization away from the hospitals, away from specialized care to GPs, to capitated arrangements that make sense for both the funder and the provider, and also other alternatives to hospitalization, such as day clinics, subacute facilities. If I look at the capitated arrangements, I think if we had those in place, and COVID had come at a time where we've got capitated arrangements, would not have the extent of income losses for providers. And that makes it a win-win for both the provider and the funder. And I think beyond COVID-19, even as we move towards UHC, the conversation should not only be about who pays. It shouldn't just be about a financing conversation. I think it should also be about how do we lower the cost of delivering healthcare for the long-term sustainability of the health sector as a whole. On the next slide, I think we really should reflect on how the private sector, the pricing within the private sector and the cost within the private sector. It should never be a question of, if you ask how much do things cost, it depends on who is asking. There's a different rate for scheme A, different rate for scheme B, a different rate for a private patient. And that on its own drives some of the challenges that we're seeing. And as I said, the issue of the hospice-centric approach. So we've got avoidable admissions that find themselves in hospital. We've got high tariffs, and that causes the unsustainable increases in healthcare costs. And ultimately, schemes are forced to increase their contributions just to sustain these higher costs. And as you do that, you lose more and more members. As the risk pool shrinks, it just becomes this vicious cycle. And the private sector, the providers in the private sector need the health financing or the health insurance schemes to survive. So I think for me, what's more important is how do we engage each other to ensure that even the pricing and the costing within the private sector is fair, so that the sustainability can be ensured. Thank you. That's my last slide.
Thank you so much. Tryphine, you've touched on some very good points, especially for hospital owners who've dialed in on what it means to do contracting, what it means to do financing and capitation. So it's not a supplier-induced demand curve. And also, we need to talk a little bit about which is the best way to reward for quality output from hospitals. Let me share my screen and put on some questions that have come through from our attendees, and we can go straight into that before we have a little bit of a dialogue. All the participants have been amazing in terms of the way they have really got through this topic for the afternoon, and I really congratulate them. So let me start with Mark. The gentleman from Ethiopia have two questions. One is, do we have clear guidance to countries from WHO on private sector engagement and also to support the private sector? Do we have guidance on that? Mark, you can take that question. And at the same time, while bringing the private health facilities on board, he asks, in the mitigation of COVID-19, does the government give them any incentives like PPE kits? We buy it for $50. We might have to charge $55 or whatever it is. So Mark, over to you. You can see the questions.
Thank you. In terms of the first question, as Tryphine mentioned, and I mentioned at the beginning of my talk, so the WHO has set up, the WHO HQ in Geneva has set up an advisory board, which includes Tryphine and Barbara, who's also on the webinar, and is establishing a work stream on private sector engagement and is putting out guidance and policy advice right now. It has a working group on COVID-19 that I'm part of, which is trying to put out evidence and documents and policy advice in the very short term and with a certain degree of urgency, given the nature of the emergency.
So we can share that, right? So Barbara and Tryphine, and so this information we can share with all the participants.
Yes, we have the link for it.
That is brilliant. So I think that answers the first question. Mark, can we move on to the next one?
Yeah, so I think possibly this, so this is a question about what is government doing to support the private sector, which is involved in the national response to COVID-19. Yeah. This might refer to the England case, so I'll speak to it with reference to my own country, England. So many people regard the United Kingdom as kind of the archetypal public sector oriented system, but there is a small private healthcare sector, mostly focused on elective surgery, but it does do one or two other things as well. Relatively early on in the epidemic, so back in late March, the NHS, the public health system here, announced that it had entered into a contract with what is called the Independent Healthcare Providers Network, which is the sort of association group, the representative group of all independent healthcare providers in the United Kingdom. Right. And the contract is focused both on COVID-19 patients, but also other urgent care priorities, so priority elective and cancer pathways. The idea being that as pressure built in terms of the COVID-19 epidemic, that that the government could look to the private sector to deliver other forms of important urgent care. So these are this is a centralized contract from the NHS centrally to provide services.
I guess Mark, I think what you're doing is saying that the contracting facility exists. And I want to tell David from Ethiopia, it's one of the issues that we are trying to tell governments here. But simply speaking, Mark, there isn't enough resources. So if I have $10 and my public health system costs me $15, how do I remove $1 from my $10 to give the private sector? You know, it's an economic question.
Yes, yes. Well, one of the things that they've done here, which may not be a straightforward option in other countries, is they've dramatically increased the allocation of budget to the Ministry of Health, to the Department of Health, and they've been able to use that to expand capacity. So the deal with the private sector is that they provide at-cost financing. So essentially, the private sector delivers services, and then they bill the public sector for the full cost of service delivery.
We have work to do. We have work to advocate for a higher GDP from Treasury. Albert, I'll move to you. Arthur is asking about quickly the demographic of patients, you know, and then how does the monies from NHIF, Rwanda get shared with the private sector? But his point really is, does private sector share same privileges as government facilities? And you can also answer Celine's question. Albert, over to you.
Thank you very much, Dr. Amit. In terms of demographic, we are having more males than females. The majority, they are between 25 years and 44 years old. We are having more than 60% as imported cases, and around 35% of local cases.
Even now, after all those days? Because in Kenya, for example, it has changed, more local than imported, but the demographic is the same. Even as of today, Albert, you have more imported cases?
Yes, yeah, we have more imported cases, especially in truck drivers.
Okay.
Who are doing cross-border itineraries.
Important point that you've made. Okay, let's move to NHIA, Rwanda, and private sector. Do they enjoy same privileges as government facilities?
Yes, in terms of the response to this COVID, they do. Being for the capacity building, personal protective equipment, time put in to respond to their request. So we are trying to harmonize and have the same behavior vis-a-vis government facilities and private facilities.
Okay, so same. If you make a call today and say, I have a patient and you're a private hospital in Rwanda, how long does it take for your rapid response to come and pick the specimen, get the test done, and give us the result?
So it will take between 15 to 30 minutes for our response team to reach the facility. And once we have the sample, it will take us between 2 to 3 hours to get the results.
Okay, something for us to learn. Rapid needs to be really rapid. Thanks. We've understood the turnaround time. Wow. Tryphine, you saw that turnaround time. Do you think in Johannesburg, you do it within a day? Is that your turnaround time?
For the testing, I cannot comment. I'm not in that space, but I know that I think it ranges between 24 and 48 hours, but I won't be the ideal person to comment on the testing, how long it takes. Yeah.
You have some questions from Arthur, long-term impact. People will have a hard time paying premiums and everything. So long-term impact is a comment there. I guess do you want to comment on it, or
I agree with that, because like I said, COVID came into a mix that was already problematic. So already we're seeing the numbers that are insured in the private sector obviously will fall over time outside of COVID because of affordability. So COVID is only going to expedite that process, and it will affect the number of, because of the job losses that we anticipate, the population that's covered will also reduce.
Yeah, and then there's the other question. I think it's also another comment, that timely settlement of bills. I know GEMS is one of the largest schemes under the South African funding system. How are you Are you paying quicker to your providers? Are you going through the vetting process? Are you rejecting claims? Or do you see yourself unleashing the payments even faster?
Even though I'm biased, I know we do. We do pay on time, and we're upfront about what we pay for. So you will not sit in a corner wondering if you'll be paid at the end of the month. We do pay our claims on time, and actually, I think one of the biggest schemes that pay a very quick turnaround time on payments.
One of the problems we've had is the volume and everything that's being dealt with and backlogs. So like NHIF has to process the claim before it settles. Even if it knows it owes the hospital $100 and there are 10 claims, they have to process the 10 claims through the whole system before the EFT is made. Do you at any one point have something called advance payment, and then when you process the claims, you can do settlement and balance of the accounts later? Have you ever experienced such a system?
So it's because I think we're a very strong regulatory mechanism. So you pay for a service rendered. You don't pay in advance before a service is. So the law in that respect protects the schemes because and also the providers. It's saying black and white that you pay only on the invoice of a service that has been rendered.
I see.
Yeah.
Okay, that makes it very clear. Jackie is saying we should probably reward quality, and will funders encourage accreditation systems? So if I'm a real quality provider, I don't have increased length of stay. I think you brought this issue of supplier induced demand, where if I keep patients for longer, I will receive more money. And the temptation for private hospitals, many of them who have logged in are listening, and they are wondering that if that is a real issue. So I do encourage all private hospital owners that quality comes before profits, and quality gives you profits in the long run. But is this something you'll incentivize, quality, profit outputs, and better rewards for hospitals? Because if you don't, the private hospitals say, well, I keep them for 3 days or 2 days, the insurance really doesn't care. So let me keep them for 3 days.
I think the different schemes have a way of engaging with the private hospitals to push for quality, to push for competitive rates. But because the hospitals don't employ the doctors, that also makes the arrangement a bit of a challenge, because some might argue that we don't keep the patients for that long. It's the doctors that do, and we don't have any jurisdiction over the doctors. But having said that, I think as an industry, we are all for moving towards reimbursing for quality. But the issue of accreditation would require, I don't think any scheme would have the skills or even the capital to deal with the accreditation. So the way we pay for hospital care, if it's a registered hospital, it's based on the registration. So if you've been registered, you've been licensed by the state, then you are eligible to claim from a scheme. But in terms of accreditation, that extra step to say we can only pay from this hospital, there has to be other extenuating circumstances to exclude that hospital from claiming.
Clear. Yeah. Jackie, you've got your answer. She's based in Johannesburg, like you. So, but I think you've made it very clear. So if they're legally registered, you pay them. But I think the sooner the insurance will give more recognition to quality, and the way you measure quality will probably change the behavior. But you know, the capitation that you brought about will be a solution, and I think capitation will drive quality, and it will sort out length of stay as well in the long run.
I think maybe there's a part about supporting transitions of care. I'm assuming they're talking about the step down from acute hospitals to maybe subacute or to rehab hospital or to the home even. Right. We are all for that. I mean, this is one thing that James pushes very hard on, because we are trying to make sure that we don't keep patients in hospital for longer than is necessary because of the cost obviously associated with this, and also the other complications, nosocomial infections and things like that. So from a point of view of saying transition of care from specialized care to step down, that's what we all want as an industry as a whole, because that will bring the efficiencies that we're looking at. Also, when you speak about transition of care, we're speaking from specialist to GP. We're speaking multidisciplinary teams, which is obviously, as a principle, is what we're fighting for, because that will ensure the sustainability of the industry as a whole.
Right. No, I totally agree. I think when you talked about doctors, and there are so many other doctors and managers and healthcare leaders who are logged in, if you feel that there is an errant doctor practicing in your hospital, either in terms of costs or length of stay, and you don't have control, I think hospital owners and managers and leaders ought to take that reign and manage it, because in the long run, you might be able to control costs. But when the supply of cardiologists and neurologists is limited, sometimes you have no choice but to take a cardiologist who may charge an arm and a leg, and eventually that raises the cost of the bills. So I think we have to take the cost of healthcare in Africa with a lens of shortages of specialists available. So it's a supply demand, also specialist care. That has an interplay in the cost of care. So I want to go quick. Yeah. Do you want to make a comment on that?
Yeah, I was just going to say that it's part of our strategy as well, because we do engage hospitals on these cost parameters, on these efficiency indicators, to say, okay, you have these 5 doctors, even if we don't name the doctor, but to say, okay, some of the issues we're experiencing with the cost pressures from your hospital are coming from maybe these 5 or 6 doctors. Maybe if you could also engage them on your side without really becoming not a name and shame kind of approach, but in an engagement, collegial kind of approach, because we do realize that there's also issues of supply and demand. There's also issues of clinical, we want to overstep our role as a funder. We want to make the clinical decisions, but we just want to make sure that we fund appropriate care. So we do have room and ways of engaging hospitals as well.
Right. I've got a question from Peter Nyaga. Send an email to me if you think there are any VATs. When you put VAT, you mean very annoying tax, correct? Not value-added tax. So if you think there are any very annoying tax to healthcare, write to us. We've been lobbying the government at KHF. We've removed VAT on raw materials for pharma. We've expunged the VAT on medical devices. If the PVOC has been reversed, we've zero rated. We continuously lobby. So do write to me and let me know if there's still some VAT or tax issues. I'll stop sharing here and ask Serish to move on to the next slides. And Barbara, we've got about, 7-8 minutes to wind up here before we...
That is correct.
That is correct. That is great. I have really enjoyed the conversations and also the quality of participants that we've had.